everyone. We're going to move on to our afternoon block. I hope everyone had a filling lunch, but not too filling. I'm Mai. I'm going to be doing the intros for this afternoon, which mostly consists of our neuromuscular rehab crew. So first up is Dr. Yumi Mitsuya. I have the pleasure of introducing her. We have offices just next to each other, and I get to work with her frequently. So Dr. Mitsuya went to medical school at Albany Medical College in New York, and then she came to Children's Oakland, at the time was called that, for residency in pediatrics, and then she did a second separate residency in adult physical medicine and rehabilitation at Stanford University. So that's it.
Hi, everyone. Thank you, Dr. Noah, for the introduction. I'm really happy to be here to kick off the rehab afternoon with my team. I see some familiar faces in the audience, so good to see you all. The title of my talk today is called The Approach to a Child with Delayed Walking, and I have no disclosures. Here's an outline of what I hope to accomplish with today's talk. This a really familiar topic to this audience already, but we'll first review expected motor milestones and what constitutes motor delay. And then we'll review the neuromotor exam and outline an algorithm for surveillance and screening of children who have motor delay. I'll list some red flags that should prompt referral to a subspecialist like a physiatrist or a neurologist when there are concerns. And then I'll describe typical gait development and some common structural and gait variations in the young child, and also talk about role of orthotics in some of these conditions. So this is probably a familiar clinical scenario you may see in your clinic during well-child visits, and it's a common referral reason to our PD rehab clinic. So an 18-month-old with no significant birth history or past medical history who maybe met early milestones but didn't crawl until about 11 months, and from there making some steady progress, and now cruising on furniture, but at 18 months not yet walking independently. So is this maybe a mild form of cerebral palsy, another neurological abnormality, or primary muscle disorder causing weakness? Do they have any structural abnormalities of their legs or feet that's affecting their mechanics? Or are they otherwise typically developing cognitively and in fine motor skills and simply have some delay in gross motor development? And we'll catch up later on. So before we get into the neuromotor evaluation, I want to first review the updated motor milestones for developmental surveillance, which was put out by the CDC and AP in Pediatrics in March of last year, 2022. So the CDC funded the AP to form an expert working group to revise the developmental surveillance checklist, updating the expected age at which most, defined greater than 75% of children, would be expected to achieve a certain milestone. And the main changes was that there were some milestones added for 15 and 30-month health supervision visits, and about a third of previous milestones were transferred to different ages, majority of the later ages than previous. Next slide. There you go. So here's a chart of the milestones that were previously used that we're all familiar with. And sorry, the text is kind of small, but lifting head and chest and prone at 2 months, rolling from prone to supine at 4 months, and from supine to prone by 6 months, sitting without support at 6 months, and walking independently at 12 months. And the general rule for what constituted a delay that would warrant further evaluation or early intervention was that if a child was 2 months delayed in reaching milestones in the first year of life, or 4 months delayed in the second year of life, correcting for prematurity for the first 2 years of life, if they were born premature earlier than 36 weeks of gestation, then you had a delay. So these were the mean ages at which a child was expected to achieve the milestone. With the updated milestones, instead of the mean age, now is the age where greater than 75% are expected to have achieved the milestone. So if they have not achieved that milestone at that age, then it's considered a delay. So the new milestone age is similar for the first 4 months, holding head up at 2 months, bringing hands to mouth at 4 months. Rolling from prone to supine is now at 6 months. Sitting without support is now at 9 months, and pulling up to stand is at 12 months. And then taking a few independent steps is now by 15 months, and walking independently is actually, it went from 12 months to 18 months. So if they're not doing these things by that age, it warrants further evaluation. Although in a lot of cases, if these delays may not be in isolation, like just a gross motor delay, so still in a lot of cases, they're being referred earlier for early intervention or evaluation. And even though the surveillance guidelines now give a child until 18 months to be walking on their own, by about 14 to 15 months, most parents, and I think us providers too, will have at least some concern if the child's not yet close to walking. And then for the toddlers who have started to take steps or walk, parents might be expressing concern about the quality of their toddler's gait, as well as some possible structural concerns like their feet are looking kind of funny, or their walking pattern's kind of funny. So our role as providers start with a thorough review of their birth and developmental history, of course, and a family history and a neurological and musculoskeletal exam to then either provide reassurance, right, or pursue workup with lab studies, neuroimaging, or place appropriate referrals. Here's an algorithm for deciding when to get neuroimaging or lab work. This was from Pediatrics in 2013. And starting at number 4, again, sorry, the text is really small, but hopefully some of you have this in your printout. If there's a neuromotor development concern identified during routine screening, but there's no concerning birth history and there hasn't been regression and physical exams otherwise normal, then you might continue to monitor closely. If there's an abnormality in tone that's noted on exam, that may prompt further workup. That can be started in the primary care setting. If there is hypertonicity, then you'd consider neuroimaging with a brain MRI. And if a child's diffusely hypotonic, then measuring a CK and TSH, just starting out with that as a screen for a myopathy. At the same time referring for further workup, usually to a neuromuscular specialist. And I think at this point, placing both neurology and PM&R referrals together works really well. At our hospital in Oakland, our neuromuscular neurologist, Dr. Fay, takes the lead in sending a lot of the workup for myopathies and other neuromuscular disorders. But if I'm seeing a 2-year-old in clinic who's standing or cruising up on their toes, and they have some hyperreflexia and spasticity at the legs, and they were born premature, with maybe had a little bit of intraventricular hemorrhage that was noted in the NICU, then I can make, on the head ultrasound, then I can make a clinical diagnosis of spastic diplegic cerebral palsy, and I might not get imaging because at that age, we still need to get the MRI under general anesthesia, which has its own risks. And proving that they have periventricular leukomalacia, MRI doesn't really change our management. On the other hand, if they have hypertonicity that's either new or with a normal birth history, then an MRI would be important to find the cause of their hypertonicity. And again, if there is concern for a myopathy, then I would, if not already placed, I would refer to our neuromuscular specialist for further workup. We used to do EMGs on kids who were referred for concern for myopathy ahead of doing a muscle biopsy for confirmation, but nowadays, with the ability to diagnose a lot of these myopathies and neuromuscular disorders with just genetic testing, we rarely do EMGs to diagnose myopathy. We still do use it for EMG and nerve conduction studies to evaluate for neuropathies. Now moving on to the physical exam. So when a child presents to our clinic with concern for motor delay, what are we looking for on physical exam? Obviously, infants and young children can't follow a formal manual motor exam. Typically, by around age 6, they can reliably follow it. And some kids can at like 3 or 4 years old if they're very mature. But most of our exam is done by looking at how much they're moving and how the quality of their movements. We observe their head and trunk control as they're being held by the caregiver in clinic, and are they looking at faces or looking around the room? What are their eye movements look like? Do they have any ptosis or incomplete eye closure? What does their cry sound like? Is it soft or hoarse, which may indicate weakness? And if they're crying and the parent hands them a bottle, do they reach for the bottle and how are they holding it? And does their sucking look coordinated? And when they reach for toys, how are they grasping the toys? Do they have any like dystonic posturing or flaring that may indicate weakness? And how do they transition from supine to rolling to pushing up with arms to being on quadruped and to standing? And what do their feet look like when they're actually bearing weight? Do they collapse medially or are they up on their toes? Are they hyperextending at their knees or crouching a lot at the hips? And in examining their arms and legs, we look at range of motion and muscle bulk. And contractures or skin dimpling in infants can be indicators of poor fetal development, which can be seen in infants with a lot of neuromuscular disorders or those with arthrogryposis. And then evaluating tone and deep tendon reflexes is really important because hypertonicity or hyperreflexia, as you all know, can indicate an upper motor neuron process, where hypotonia or hyperreflexia can be seen in many genetic disorders as well as neuromuscular disorders. And Dr. No in her talk will go over more of the spasticity evaluation in particular. But in older infants, we're also looking for persistent primitive reflexes like the Moore or ATNR, which should normally extinguish by 4 to 6 months of age. I didn't include this in my talk for this year. I talked about it a little bit last year, but for cerebral palsy specifically, there is a physical assessment called the Prechtel General Movements Assessment that's done early in infancy, particularly in the NICUs for premature babies and babies with hypoxic ischemic encephalopathy for early diagnosis of cerebral palsy. And we traditionally didn't formally diagnose cerebral palsy until about 2 years of age, but in recent years, there's been an emphasis to diagnose early, or at least diagnose with make a diagnosis of being at high risk of developing cerebral palsy so that we can get these children hooked into services and early intervention sooner and also reduce family stress of not knowing. But in the clinic, these are some of the red flags that we're looking for in the history or in clinical exam. Rolling before 3 months is usually abnormal, and most of the time due to hypertonicity or posturing that throws them into rolling. At 4 months, a child who lacks head control, who demonstrates scissoring at the legs, indicating some adductor muscle spasticity, would be worrisome. At 6 months, the persistence of primitive reflexes, again, which should have integrated and disappeared by then, is a concerning sign. And then sacral sitting or W sitting can be a sign of poor truncal control. Commando crawling or inability to come up the quadruped on arms and knees may indicate spasticity at the legs. And then a hitching type of crawl can indicate hemiparesis, weakness, or abnormal tone on one side of the body. Some other red flags from physical exam and diagnostics are listed here. In muscular dystrophies, you generally see CK levels that are more than 3 times the normal values. Physical exam findings that are concerning for motor neuron disorders may include fasciculations, which are seen in conditions like spinal muscular atrophy, and facial dysmorphisms, organomegaly, and cardiac abnormalities. You're going to be worried about some glycogen storage diseases possibly. And developmental regression with loss of motor milestones is an obvious red flag that would warrant neuroimaging and genetic testing for neurodegenerative conditions like Rett's or leukodystrophies. And loss of motor function with minor acute illnesses may raise suspicion for mitochondrial disorder. But what if you're seeing an 18-month-old in clinic who's not yet walking? They may or may not have had some fine motor and or speech delay, but their exam is normal with no red flags that we mentioned. You might ask yourself, or the parent may ask you, what's the chance that there's an underlying abnormality? So there's not a lot of studies that really looked at this question in a very systematic manner, but probably the most relevant prospective population-based study to date was one that was done in England in the 1980s. And in this study, they prospectively followed children in the county called Oxfordshire, which is a little bit outside of London, who at 18 months was still not walking independently, with walking independently defined as taking 5 or more unassisted steps. And they estimated having screened about 80% of the pediatric population in the county, and there were a little over 400 children who were referred during a 4-year period, which accounted for about 1.6% of all 18 months olds in that county at that time. And about 30% of them had a known diagnosis, with the majority of them being cerebral palsy. And in those that had, in those who didn't have a previous diagnosis that explained the delay in walking, the incidence of newly diagnosed neurological abnormality was about 7%, which mild forms of cerebral palsy made up for about a third of these children. And they didn't elaborate on the other neurological abnormalities or diagnosis that accounted for the other two-thirds. But if they had a normal neurological exam or a diagnostic eval and diagnosed with idiopathic late walking, over 90% of these children eventually achieved independent walking by 2 years of age, or about 6 months after they started taking some steps. I included this slide to give an idea of what we see in terms of average age for achieving independent ambulation in children who have known underlying conditions. For children with spastic diplegic CP, generally if they achieve sitting without support by 2 years of age, then they have a good chance of walking by 3 to 5 years of age, and in many cases requiring ankle-foot orthoses or ankle braces. And depending on the degree of involvement, may also need a walker to walk independently, but they can in those ways achieve independent ambulation. In kids with Duchenne muscular dystrophy, mean age for onset of independent walking ranges from 15 to 20 months across different studies and data sets. And in kids with Down syndrome, most will have some gross motor delay, with mean age for cruising being around 18 months and walking independently around 2 years. And in children with spina bifida, if their myelomeningocele or functional level is L4, where they have good hip flexion and knee extension, most can walk with the aid of AFOs and maybe a walker or forearm crutches by the time they're about 4 years of age. But as they get older and put on more weight, many will lose community level ambulation, though they may still be able to ambulate short distances within the home. And if their level is sacral, then they may have some ankle dorsiflexion and impaired ankle plantar flexion or absent ankle plantar flexion. But they typically walk around 2 years with or without AFOs, though they might have some deviations in foot positioning and gait pattern. So walking is such an automatic movement we do daily, but when you break it down, human gait is really complex. And it involves intricate interactions between the pelvis, hips, knees, ankles, and involves a lot of highly coordinated cyclical series of movements. And I won't go into too much detail, but the gait cycle consists of 2 phases, the stance phase and swing phase. The stance phase accounts for 60% of the gait cycle and starts with a heel strike when your heel touches the floor, and it ends with toe push-off. And the swing phase occupies the remaining 40% of the cycle and begins after toe off, where you swing your leg forward, and ends when the heel strikes the ground again to start another cycle. It's likened to vaulting over an inverted pendulum, where one leg is bearing weight while you're simultaneously swinging the contralateral leg in a synchronized fashion. And there's not a lot of vertical movement right at the hips or sway at the trunk. and the stride or step lengths are regular and controlled. When a child first starts to walk, though, you see short, quick, rigid steps, lots of trunk oscillations and vertical hip displacements, with the toddler having a wide base of support and carrying their arms up in high guard position as they're trying to keep their balance. Their hips and knees remain slightly flexed, and they'll lift their foot high above the ground during swing and then make flat-footed contact when their foot comes down to the ground instead of doing a heel strike, typical of a mature gait. And it's around 2 years of age that you start to develop the heel-to-toe pattern, and around age 3 to 5 is when you start to develop an arch in the foot. I know, I think Dr. Livingston covered the topic of in-toeing and out-toeing in this morning's lecture, so I won't go into much detail here, but we'll review that it's typical to have some genu-varum or bowing of the legs initially. Then at 18 months or about 6 months after the onset of independent walking, the knees become straighter and less bowed, and they're able to stand more upright and able to extend their hips more than previously, stop having excessive movement of their hips out to the side when they walk. And around 3 years of age, you might see the alignment change to appear more knock-kneed. And the rotation of the bone in the upper leg continues to be twisted somewhat with some femoral anteversion or tibial torsion. But by age 4, the walking pattern is mostly mature in most kids, and by 7 years of age, the alignment tends to also normalize, where the legs are mostly straight with some bowing or knock-knee alignment in some kids, and mild out-toeing, where you might see 2 toes out when you look from behind the heel. One of the more common things we see in children referred for gait assessment to our clinic is pronation, where you see collapse of the medial part of the foot. And pronation actually is comprised of 3 main components, or what we call triplanar movement of the foot and ankle, which are 1, calcaneal valgus, 2, collapse of the medial arch, and 3, forefoot adduction, turning in. And flat foot is typical in infants and young children, as we mentioned earlier, that arches don't really start to develop until about 3 to 5 years of age. But excessive pronation can lead to some delay and deficits in walking. So we see this most commonly in children who have hypotonia for whatever underlying reason. And these children also present often with ligamental laxity and have increased range of motion at the ankle. It's common to see these children be mildly delayed in pulling to stand or cruise, or they may reach those milestones on time, but then may plateau and not progress to taking independent steps as quickly as expected. Or they might take steps, but they continue to fall very frequently. And the reason for this might be multifactorial, including, they may also have some decreased postural control or proprioception impairment that will continue to, develop and progress in a good way over time. But excessive pronation causing an unstable base of support can be a significant factor that may be limiting their timely progression. So what do we do for this? Well, if a child has delayed walking, they've probably been referred to physical therapy, and the physical therapist will be working with them doing play-based activities to try to facilitate movements that would strengthen the foot and ankle muscles, as well as the larger stabilizing muscles, including the quadriceps and the hip girdle muscles, so that the whole chain can work more efficiently. But when there's excessive pronation, there's a role for bracing, and in most cases, an SMO or supramalleolar orthosis, which is the shorter brace that comes right above the ankle, is enough. SMOs help with guiding the heel into proper alignment. So if their calcaneus is an E version, it stabilizes to a more neutral position. It also lifts and supports the arch, and keeps the toe in alignment with the rest of the foot. And I've heard arguments against using an SMO in a child who has just mild gross motor delay. And one of the arguments I often hear is that bracing them would not allow free movement of their foot and ankle, so it prevents muscle development or natural strengthening. And I've talked to a lot of veteran physical therapists, some who are in this room, and the general approach is that if pronation is severe enough that there's eversion of the heel, there is benefit to supporting their foot with an SMO. And from my perspective, I think there's two main reasons. One is that when you optimize the position of the foot, it allows for better timing and strength of the muscle activation so that you're actually working the muscle more efficiently. And in hypotonic muscles, the muscle spindles aren't pulled as taut, so it tends to require a greater stretch of the muscle before they're activated. And this delays the signals to the brain that synapse on the alpha motor neurons that tell the muscles to contract. So this delay in muscle activation can appear as weakness, but when the positioning is in an optimal alignment, then the timing of the contraction can become more typical and you can get stronger activation of the weak muscle. And by having your foot in proper alignment, I think it also helps with proper development of the muscles higher up the chain, including your hip muscles. And the other reason is to consider bracing is to support development of the foot and ankle. Bracing doesn't fix the pronation, right? And I make this clear with the family. It only supports the foot and ankle, but and most kids with mild or even moderate hypotonia who walk will eventually build strength enough so that we can wean them off of SMOs because their hyperpronation over time does improve. But if their feet's not supported and their ligaments get overstretched, the pronation can become more difficult to correct as they grow. And if they get older and then their bones then ossify in this pronated position, then they'll continue to pronate into adulthood, which can cause pain or easy fatigue. And another common gait abnormality we see a lot in our clinic is toe walking. And we said earlier that classic toddler gait is flat-footed, but toe walking or intermittent toe walking is something a lot of toddlers do and is a normal stage in gait development. However, it is something that should resolve within a couple of years, and it's really rare to see it past 5 years of age in typically developing children. Kids who toe walk most commonly present to our clinic in the first 1 to 2 years after they start taking steps. Families usually report concerns about the child having poor balance, frequent falls, or not keeping up with kids their age. And older children might complain of muscle cramps, foot pain, or fatigue with walking long distances, and might be prone to ankle sprains or calluses at the balls of their feet. Causes of toe walking can be various. So in addition to the range of motion and musculoskeletal exam, again, we're doing a thorough neurologic exam to look for things like cerebral palsy, tethered spinal cord, or muscular dystrophy, which are the other common causes of toe walking. And autism spectrum disorder is not a cause, but does have a strong association with toe walking due to sensory processing differences likely. And if a child walked normally at first and then started toe walking later, then it raises suspicion more for a neurological or neuromuscular process. But if it's an otherwise typically developing child with no other concerning exam findings, then we label it idiopathic toe walking. And the majority of kids with idiopathic toe walking walk at a normal age, and when directed to do so, they can stand on their heels on the ground as long as they haven't developed contractures or decreased range of motion. And even when they walk, they may be up on their toes and then intermittently might bring their heel down and sometimes do a heel strike and then a toe off, typical of a more normal gait. Idiopathic toe walking was previously thought to be exclusively due to habit, but there's an association with differences in motor control, sensory processing, sometimes vibration perception thresholds. And in a lot of cases, parents and families do report a family history like, oh, his father toe walked or a sibling toe walked when they were younger. Long-term natural history studies are limited, though most, like I said, do resolve during grade school years. And optimal treatment is not fully elucidated. But main goal of management is to maintain range of motion at the ankle so that kids don't develop plantar flexion contractures that will make it harder or even impossible to walk with the heel down later on. Simply cueing the child to walk on their heels with frequent reminders hasn't been shown to be effective. Even studies looking at PT and stretching exercises in these idiopathic toe walkers haven't proven to be very effective. Using AFOs to block the plantar flexion and forcing them to bring their heels down works when they're wearing the AFOs, but as soon as they take them off, they tend to go right back up on their toes. So general rule of thumb, if they're younger and still have a lot of flexibility with their ankle, able to be dorsiflex past the neutral position, then we may just observe. And if their toe walking is more mild, but they are developing some ankle tightness, then I often prescribe ankle stretching splints, which are basically articulated or hinged AFOs that with straps that you can pull on to adjust the dorsiflexion degree. And I have them wear it for at least 2 to 3 hours a day when they're sedentary or sleeping to really get a good stretch on their Achilles so that their range doesn't get worse. If they're really high up on their toes or they've started to develop restricted range, then I recommend daytime or walking AFOs that I have the child wear basically all the time when they're walking outside, like at school or park. And if they've developed decreased range of motion where we can't get them to neutral position or above, then I recommend serial casting to improve the range past neutral, and then after serial casting, transition them to walking AFOs. And Botox injection is typically not indicated in idiopathic toe walking where spasticity is absent. But if someone has severe contractures where I don't think they would tolerate the serial casting without Botox, then I might consider it. And then if they are older in age or if the contractures are really severe, then I refer to orthopedic surgery for surgical lengthening. Okay, and then lastly, I just wanted to throw this in here since it's a question we do get asked a lot, which is about using a baby walker. So we as pediatricians generally recommend against it, right? Because babies can sometimes move really quickly in these things, risking injury from falls downstairs or even smaller steps that can sometimes result in serious injury like a head injury. But despite this, it remains really popular with parents. And there's a lot of commercial baby walkers on the market. I see a hand in the back. Okay, thank you. Medical providers, including physical therapists, have also discouraged use with the thought that walker encourages walking with learning abnormal walking patterns like forward-leaning trunk and toe walking, and doesn't strengthen the core and hip muscles enough so that the child may learn to walk in this abnormal way, and it might delay development of a normal gait pattern. And past studies that looked at this, which were mostly observational studies, were really inconclusive on harm versus benefit. There was a study that looked at whether there were differences in gait mechanics, though, between these toddlers who used baby walkers and those who didn't, and whether there was a difference in when the timing they achieved independent walking. It was a small study with only 16 toddlers in each group, but it was interesting because they actually used instrumental gait analysis to really look at differences in gait kinematics. They recruited participants by asking parents at infants' 6 to 9 month well child visit about their opinion, the parents' opinion on baby walker use. And if they were interested in using a baby walker, they were randomized to the baby walker group. And these were all babies born full term with no complications and with gross motor development score about above 10th percentile on the AIMS or Alberta Infant Motor Scale. Parents in the baby walker group documented the amount of time the baby spent in the walker, which ranged from like 45 minutes usually to an hour and a half or 2 hours a day. And first measurement of the gait, like the gait analysis, was done on the week that they acquired independent walking, which was more than 5 steps. And they did these measurements monthly until 6 months after they started walking on their own. And they found that there was no difference in the age of independent gait acquisition between the two groups. They did find difference in the gait kinematics, where the baby walker group had lower gait speed and longer duration in stance and swing, as well as some differences in knee and hip movements. But these differences disappeared in the month following gait acquisition. So use of baby walker may not be harmful, or at least may not have long-lasting effects on gross motor development of otherwise typically developing children, but I still recommend against it due to the risk of inadvertent injuries. So that was a lot of slides for me to make these very simple take-home points. For surveillance purposes, children should achieve independent walking by 18 months of age, but if there is global delay or any abnormal physical exam findings, refer early. Toddler gait evolves, but should develop a heel-to-toe gait around 2 to 3 years. And delayed walking or abnormal gait pattern with excessive pronation or toe walking present, then I would consider bracing. Thank you.